I think that over the last 15 years, we have developed in the laboratory a new way of trying to treat cancer, and that way of treating cancer is to modify genetically a patient's own immune cells, or T cells, in such a way that the T cells, the patient's own T cells, can now recognize and kill off cancer cells. And we started that process off initially targeting a protein that's expressed on a lot of B-cell type tumors, such as non-Hodgkin's lymphomas, chronic lymphocytic leukemias, and acute lymphoblastic leukemias. And that target is CD19. And so early on in the laboratory, we started developing this technology and demonstrating that we could redirect T cells in Petri dishes, and subsequently in several different mouse models of B-cell cancers, we were able to eradicate these diseases. Now, over the intervening decade, we have moved this technology into the clinical setting. And with that translation to the clinical setting, we have found that particularly in cancers such as B-cell acute lymphoblastic leukemia, where in adults the prognosis is dismal, we are able to achieve almost a 90% complete response rate in chemotherapy refractory disease, which is a striking response, and it has garnered a lot of interest in our technology. A chimeric antigen receptor, or CAR, is a Frankenstein-like molecule that is made up of a recognition domain, which most commonly is derived from a monoclonal antibody, that's fused to the signaling domain of a T-cell receptor. And so the gene that we construct in the laboratory to encode for these chimeric antigen receptors, or CARs, can then be inserted into an immune cell, a T-cell, to act as a surrogate T-cell receptor to allow the T-cell now to recognize what it would otherwise have ignored, such as the CD19 protein, which is a self-protein, and the immune system is not geared to target it, even if it is expressed on cancer cells. And so these re-educated T-cells can now be infused back into the patient after this gene therapy approach in the laboratory, and these T-cells will then root around and find the tumor cells and kill the tumor cells. To date, we have expanded multiple clinical trials wherein we target these B-cell cancers in patients with, initially with relapsed and refractory chronic lymphocytic leukemia, and subsequently in what we thought would be the more challenging, more rapidly growing B-cell acute lymphoblastic leukemias. We have since expanded our program to include treatment of B-cell non-Hodgkin's lymphomas in the context of autologous bone marrow transplants. As well, we have expanded our acute lymphoblastic leukemia studies to include patients that have relapsed even after an allogeneic bone marrow transplant. The most promising results, not only at our center, although we were the first to report them, but also at institutions such as the National Cancer Institute in the United States and the University of Pennsylvania, have demonstrated consistently high response rates in patients that have a poor prognosis, i.e. patients that have relapsed B-cell ALL, where other options, certainly in the adult population, are very minimal, and the success rate is actually very poor. Right now, the technology is restricted by what we can target. And so right now we're looking at B-cell cancers because they all express the target antigen CD19. The advantageous aspect of targeting CD19 is that it's not expressed on normal tissues except normal B cells. And in most cases that have been reported today, these normal B cells eventually do come back. And in those cases where it doesn't come back, you can compensate for this on-target, off-tumor toxicity by giving monthly intravenous immunoglobulin infusions. Now, to expand the technology to other hematologic malignancies, such as myeloid malignancies, it requires identification of suitable target antigens on those cells that are not expressed on otherwise essential normal healthy tissues. And so that will remain, moving forward, a challenge in the field of this type of therapy, is the identification of proper targets to other cancers, not just other hematologic cancers, but also very challenging in trying to target solid tumor malignancies where the immunologic background and issues that are involved in these tumors are much more complex, we believe, than they are in the acute lymphoblastic leukemias and chronic lymphocytic leukemias. So the issues that are raised in the field right now are probably threefold. The first issue clearly is being able to generate T cells that can fully eradicate tumor cells and identifying antigens that we can target on these various tumor cells. Now, once you've generated a T cell that can relatively safely target a tumor cell, the next challenge is to combat the tumor itself, because the tumor surrounds itself with a lot of immune suppressive elements, such as regulatory T cells, which inhibit T cells, cytokines such as tumor growth factor beta, TGF-beta, and IL-10, as well as other cell types such as myeloid-derived suppressor cells and tumor-associated macrophages, all of which work in concert to inhibit the function of these genetically modified T cells. In addition to this, the tumor may express ligands such as PD-L1 that can directly inhibit the T cell as well. So these issues need to be addressed. And at this meeting, I present one approach, which we call an armored car approach, wherein the T cell is modified not just to recognize the tumor, but also to be able to persist and continue killing tumor cells, even in the context of the immune suppression that the tumor may surround itself with. The third issue that has to be addressed, which we found very early on in our studies, is, and as well as at other centers, is that there is a degree of toxicity associated with this therapy, specifically what we call a cytokine release syndrome. And this is, for the patient, like a very, very bad flu, in the sense that what happens is that these T cells are immune cells, and they reach their target and they become activated. And when they become activated, they set off a cascade of high levels of cytokines causing fevers, can cause mental status changes, and low blood pressure. And so many of our patients, despite having very good outcomes, and despite the fact that these side effects are highly reversible, do spend time in the intensive care unit. And so that third challenge is for us to be able to harness the anti-tumor effect, and in the meantime minimizing the side effects of this immune response, this cytokine release syndrome. And by adjusting the doses, we perhaps can try to avert some of these side effects. It's certainly, as with any drug, I mean, we would be a little reluctant to combine these T cells, obviously, with standard chemotherapies, which may be cytotoxic to the T cells themselves. But the field of immunotherapy, with the inclusion of immune checkpoint inhibitors, which are discussed at this meeting as well, shows that there probably, on paper at least, should be significant promise of combining these CAR T cells along with these immune checkpoint blockade agents, antibody agents, which could serve kind of as an escort for the T cells to allow the T cells to persist, again, in that very immune suppressive tumor microenvironment. So the take-home message here, it really is that there is a lingering question. Given the fact that at multiple centers this approach has demonstrated significant promise in the field of B-cell acute lymphoblastic leukemia, wherein it works the best, the question arises, is this a proof of principle, or is this simply a very innovative and new way of treating B-cell ALL? I personally believe the former, which is to say that we can show that redirected T cells can eradicate systemic cancers in humans, and that the challenge moving forward is how do we harness that technology optimally so that we can target many more types of cancer, many more prevalent types of cancer, not just by creating better T cells that can overcome the tumor microenvironment, but also through the identification of suitable target antigens on those tumors. It is a type of therapy that has garnered a lot of interest. As I point out in my disclosures, we formed a company, Juno, to be able to afford to run a phase 2 trial, because this technology is expensive and requires a significant amount of capital to push these phase 1 studies into a phase 2 to allow for FDA approval. And so the interest in these early studies has certainly caught the attention of the academic world, which explains why I was so kindly invited by the organizers to come speak here today, but also in industry where formerly this type of therapy, this personalized therapy, was not felt to be an economically viable approach. And I think industry has significantly rethought that, and with the advent of multiple companies now in this space, I think we're going to see that that this is indeed a viable and economically viable therapeutic option. And as long as the results remain as outstanding as they have been, I foresee that this is going to potentially significantly change how we look at cancer therapy.